Let's look at some of the things new to pediatric radiography that we can utilize to improve our images. As healthcare professionals, we must understand how to provide quality healthcare to children as well as adults. We often think of children as just small adults, but that's certainly not the case. So we need to have some techniques which include communicating effectively with both parents and child, respecting the child's rights, and performing exams in a manner consistent with the needs of the pediatric patient. To begin with, pediatric anatomy and physiology differs from adult anatomy and physiology, and the tissues also have different densities which impact upon our imaging techniques. The radiographer doing pediatrics needs exceptional communication skills to communicate with not only the different aged children, but the parents of the children. It takes time and effort to develop the ability to work with pediatric and adolescent patients, just as every other radiologic exam requires an evolution in skills. Communication is most important in pediatric radiography. The pediatric radiographer needs to start with an increased knowledge about human development and the subtle differences that exist between age groups, such as toddler and preschooler. In addition to that, they need to understand radiation safety and be able to explain to the parents and the children the new policies about radiation protection. After 70 years of research, we've come up with currently that shielding for radiation, ionizing radiation, is no longer recommended for children, and we no longer need to ask the adolescent, is there any chance of you being pregnant at this time, which often makes the examination difficult and the interaction with the teenage girl difficult. For pediatrics, we're getting back to basics on a lot of the imaging and using techniques charts as opposed to anatomic programming, because the anatomic programming is designed for adults. Digital imaging provides no clue at the monitor whether your exposure was correct or incorrect just by looking at the image. You have to know the exposure indicators, the KVP, the mass, the SID, and the exposure index number that's displayed. All radiographers know that ALARA, or as low as reasonably achievable, means making every effort to reasonably maintain exposures to radiation far below the dose limits consistent with the purpose of the activity. This is especially true for pediatrics because the ionizing radiation they are receiving is cumulative over their lifetime, and their tissues have a different sensitivity than adult tissues to ionizing radiation. With digital imaging, the amount of exposure is actually the amount of data that you have. The more exposure, the more data, and the easier it is to create an image. The computer takes the data that you have given it and creates an image that you are expecting to see, regardless of the amount of radiation that you have. Of course, the caveat to that is if you're underexposed, we get those grainy images because a computer cannot pick up anything that it does not actually have as information and put it into the image. When we first transited from film screen to digital imaging, what we found was that many CT techs were doing pediatric patients on adult exposure techniques, and the CT program was changing the images to look good because the overexposure gave them a lot of data to utilize. Here we can see how a digital program tries to give you the image that you're looking for. We have 3 exposures here. One is underexposed, one is the correct exposure, and one is overexposed. A histogram is a 2-dimensional map of the exposure that was taken. So here we can see the same histogram with an H&D curve or a D log E curve, an exposure curve over it. And notice on the H&D curve, B, or the middle type of image, is the correct exposure, because the straight line portion of the exposure on the H&D curve is what we're looking for. If you look at A, we have the toe on, which means it's underexposed, and C, we have the shoulder on, which means it's overexposed. Today, in 2023, scientists and researchers know more about how radiation affects the human body. Scientific evidence shows that routine diagnostic or low-dose images do not expose the patient or fetus to harmful levels of radiation. After 70 years of shielding routinely and asking if there's any chance of pregnancy, pregnant mothers or parents of children being imaged may be especially anxious about this change, because we've drilled it into their heads: radiation is not safe for you and your children. In addition, with all of the online information available, this information is not currently well known by most of the public, and they still get information about the hazards of radiation exposure. But low-dose ionizing radiation used in routine radiology is perfectly safe if used correctly. Well, yes, radiation can harm a fetus, but only at exposures above 100 millisieverts. Take a moment and think, what is the maximum exposure that you can get as an occupationally exposed person utilizing ionizing radiation? It's 50 millisieverts per year, a number considered to be absolutely safe. 100 millisieverts is twice that amount of radiation. Well, where did all this misinformation come from? Basically, in the 1950s, doctors began to shield reproductive glands and a pregnant woman's fetus during medical imaging. At the time, medical experts were unsure about the long-term effects of radiation exposure to an unborn fetus and to reproductive cells of the testes and ovaries. They were also concerned about damage to reproductive cells and could it be passed to future generations. Here we have a graphic chart which shows a pregnant woman, the probability of bearing healthy children as a function of radiation dose received during the pregnancy. Millisieverts is the dose occupationally, and milligray is the amount of dose that the patient actually receives. Here we see from 0 to over 100 milligray that the fetus receives. So now let's take a look at the probability of actually having a normal fetus even though they're exposed to radiation. There are times that you will have an abnormal fetus even if there is no exposure to radiation. And our chart shows that the exposure from 0 to 100 milligrays is exactly the same. Above 100 milligrays, there is a possibility of a malformation. Well, let's see what happens if we expose the fetus. What is the possibility of them not getting cancer? Because remember, everyone can get cancer from the years 0 to 19 years of age from the exposure. You can see in total there's only a total of 0.09% if you get 100 milligrays or higher to begin with. So 100 or more milligrays of exposure would be equivalent to double the amount of exposure that an occupationally exposed person can get per year. Remember, we can get 50 millisieverts per year, and that would be the equivalent of 50 milligrays. Depending upon the type of radiology employment, the terms pediatric and adolescent may be used every day. Individuals in these groups should not be treated simply as smaller adults, but require a radiologic technologist with flexibility and patience and knowledge base to acquire images for this group. Children vary in size from tiny premature babies to very obese teenagers. This makes it especially important for pediatric radiographers to adjust technique and select the optimum exposure, including the minimum time for exposure, to compensate for the motion that may occur while imaging pediatric patients. For example, the less calcified bones of young children may require a different or lower kVp to penetrate the tissue compared to adults. And automatic exposure settings are used for adults cannot be used to image children. Radiographers may need to manually select exposure parameters to get the proper exposure for pediatrics. The automatic exposure control should only be used on larger pediatrics, basically adolescents. How about the image environment or atmosphere that we have for pediatrics? Remember that you have someone who is physically and emotionally different than an adult, and if you have the ability to provide an atmosphere such as an imaging room or a waiting room that is designed for children, it is beneficial to the pediatric radiographer. In the pediatric waiting room, it would be nice to provide distractions to reduce the child's anxiety and reduce the parent's anxiety and tension as well. By using gender-neutral toys as an attraction for the children, you'll probably cut down on the number of fights over, "It's mine." It is extremely important in pediatrics that you have everything set up that you need to have to do the examination prior to the patient coming into the room. If you have to dim the lights or gather immobilization devices or different types of things that you may need for the exam, it's going to take time and it's going to cause frustration for both the parent and child waiting for the exam. What if you're in an emergency setting? Now the rules change. No longer are you in a calm waiting room, but you're greeting a child in pain and worried parents. The pediatric radiographer must maintain a calm perspective and provide reassurance to both the patient and the parents. The radiographer should greet the parents and describe the procedure. It is best to only have one caregiver to come into the exam room and give instructions to the child and help with the procedure. More than one parent or caregiver in the room can cause chaos and the child gets frustrated. After the procedure is finished, tell the parents where to wait and what to expect and when to expect it. They're very anxious because to them, this is the primary emergency of the day. Obviously, the outpatient setting is much less stressful than an emergency situation. The outpatient setting does have some problems. Basically, lengthy waiting times can be very frustrating. People don't really communicate very well to the patient, and the patient wants to come first and have their services done now. You can only listen calmly and sincerely to the patient and try to communicate to the best of your ability that you are going to get them taken care of in the best manner possible. When you had an emergency coming in and the patient would be rolling past, whether it's a gunshot wound, a knife wound, or a car wreck, the outpatient setting, and the outpatients would holler, "Hey, I was here first." So we've talked about x-raying the patients from the outpatient and the emergency, but how about the inpatient setting? Many inpatients can come down to radiology and are similar to outpatients, but many of these patients also need portable examinations. And portable examinations scare the patients because now you're coming lumbering in with this big piece of equipment and they don't know who you are and they're pretty fearful. Meanwhile, parents are occupied with multiple tasks and concerns. They look around and see you there and then wonder what's going on. This is a time when your communication skills need to be at their best. When communicating about the exam, if the child is capable of understanding a direct explanation to the child of what you want them to do and how you want them to do it is best. If the child is too young to comprehend, direct the explanation to the parent and let the parent work as a helper. Use short, simple sentences that everyone can understand. When a parent is participating in the exam with you, you should be obviously professional and show courtesy at all times to both the child and the parent. You also need to do what? Watch both the child and the parent in the room to make sure that they're safe and assist with immobilization of the child prior to making your exposure. When interacting with the child and approaching the child, you need to introduce yourself first. You need to talk to the child at his or her eye level and use the child's age to determine the approach that you're going to use in communication and doing the examination. So let's look at the different skills required for the different ages, and we'll begin with birth to 6 months. At this age, the child requires warmth, security, and nourishment. The child does not distinguish among caregivers, and if in fact they've gone obviously to the lab first and see you as a caregiver after getting stuck by someone at the lab, you're going to have a loud child on your hands. These children are often startled by loud stimuli, and as you know, there's a lot going on in the x-ray room, but they can be comforted by using a pacifier. The next one's kind of a rough one, 6 months to 2 years. They're fearful of pain, they're fearful of being separated from their parents, and they have limitations to their movement. They're going to require assertive immobilization techniques, and parental participation is often helpful in the exam. At approximately 1 year of age, children begin to develop memories, ideas, and feelings. A child who has previous experience with health care, such as an injection, may panic at the sight of another white lab coat. They can have temper tantrums, and the word no is often frequently heard. Between 2 and 4 years of age, they're kind of fun, and actually they respond to praise and are very curious and enjoy fantasy and games. They'll cooperate readily if they're treated like they're in a game or doing a game with you. Just take your time, be friendly, and enjoy the exam. Preschoolers can be a challenge because of their socialization skills and increased verbal ability. They typically have numerous questions. This age is very trusting, so answer their questions honestly on an appropriate verbal level. Again, allowing a favorite toy may ease their anxiety. Preschoolers have a very short attention span, so be prepared to repeat your instructions. They enjoy praise, so give them positive comments such as, "That was a great job. holding your breath, or that was a good job holding still. 5 years of age is very interesting. Their responses vary widely, from the confident children who respond with advanced maturity to the scared child clinging to the parent and acting much younger. At this age, they enjoy mimicking adults, and hopefully the adults they mimic are kind and polite instead of bullying and loud. Children from 6 to 8 years of age are eager to please and easy to communicate with. They're also very modest. And what you need to do is communicate with them when you're doing your palpation for positioning them. Explain what you're doing, how you're doing it, and why you're doing it at their level. Preteens and adolescents. Many of us remember that well. Actually, with preteens and adolescents, they're often worried about what their recovery time will be, and they need clear explanations to the questions that they have for you, and they need to be answered correctly. They want to be treated as adults, but may be sensitive to issues such as menstruation and pregnancy. Although we've gone through the age ranges, we also need to talk about special needs pediatric patients. With special needs pediatric patients, you need to consider the age of the child, begin communication with the child, and continue to make eye contact. Talk to the child rather than about the child, and have the caretaker assist you during the examination. As we've discussed over and over, communication is very important with children. It's good to praise them, give them reassurance, and have a conversational distraction with them while you're doing the examination. These are skills that are learned over time. One of the skills that is very useful for a pediatric radiographer is the use of immobilization devices, and you'll find that tape has become your best friend. You need to be familiar and competent in providing immobilization with different devices or wrapping techniques. Now we'll go into a very serious subject that we need to make sure that you understand, and that is pediatric anesthesia. Institutions that sedate pediatric patients must follow guidelines established by their anesthesia department, and the anesthesiologist department is the group that responds to emergency situations caused by the sedation process. The child should always have a qualified nurse or person available in the room with them and watching them during sedation. Sedation of a child or an adult is out of the scope of practice of the radiologic technologist, and they should not participate in this other than assisting the anesthesiologist. Obviously, there are a myriad of exams and modalities that we utilize for diagnostic imaging of pediatrics. Let's take a look at some of the common routine X-ray exams and imaging specifics for the pediatric patient. Obviously, the chest X-ray is the primary exam that all radiologic technologists do, and about 80% of the children need to have a chest radiograph along with other radiographs when they're in the hospital situation. The chest X-ray is one of the most common radiological investigations undertaken in the practice with children. Chest X-rays are requested for a number of suspected diagnoses, including pneumonia, pneumothorax, and foreign body aspiration or ingestion. Let's begin by looking at some of the common reasons for doing a pediatric chest exam. Of course, cardiac disease, the heart, bronchitis, pneumonia, tuberculosis, pneumothorax, respiratory type disease syndrome, traumas, foreign bodies, septic screening, and looking for location of those patients' lines like the endotrache tubes, PICC lines, etc. when they're in the hospital. Which of these two x-rays shown is an emergency type of situation? The tension pneumothorax is obviously the emergency. The other chest x-ray is obviously a diagnostic chest x-ray, but we can see the endotrache tube and the lines on the patient. Standard projections for the chest x-ray for pediatrics and neonates is a PA erect, AP erect, AP supine, and AP supine for the neonate. Erect PA chests are performed on older patients, but not advisable for the younger patients due to their lack of attention span. Although we'll get some magnification, an AP erect is ideal for a cooperative younger child between the ages of 3 to 7. They're easy to position and immobilize in this position. The AP supine chest is performed when imaging, say, an unconscious or uncooperative child. And as shown in this image, we do an AP supine also for the neonate in the neonate unit. Let's look at some additional chest projections. The lateral view. The lateral view is not often performed in pediatrics, but it can be used to highlight pathology within the mediastinum, show the costophrenic recess, and localize lesions or foreign bodies. We can also do a cross-table lateral view, and this is used in patients under the age of 6 months. It's not often performed in pediatrics, but again, it can show pathology in the mediastinum, the costophrenic recess, and localized lesions. Obviously, after the chest, we're going to look at the abdominal radiograph. The abdomen radiograph is a commonly requested examination in the pediatric patient. Children that present for abdominal x-rays are often very unwell. Therefore, specialized techniques and appropriate communication are essential for gaining the child's cooperation. Also, the radiologic technologist must be aware of the type of techniques to be used to demonstrate the pathology that is requested. There are a number of indications for performing abdominal radiographs, ranging from swallowed foreign bodies down to inflammatory bowel disease. Here we have a list of the indications that are commonly seen when doing an abdominal x-ray for a pediatric patient. In perusing the list, you can also see the need for different techniques to be utilized in demonstrating pathology. We can see the differences in techniques for intusception, where the bowel folds in on itself or is telescoping in. We have one technique, as opposed to a pneumoperitoneum, in other words, air in the peritoneum, we have another technique. And finally, for Crohn's disease or for irritated bowel, we might use a contrast study. Ingestion of foreign bodies is a common pediatric problem. Believe it or not, there are more than 100,000 cases occurring each and every year. In many cases, you'll need 2 orthogonal views of the ingested article so that we can locate it exactly and then treat the child accordingly. What if they actually aspirate the foreign body and it's something like a Lego that will not show up on X-ray? Objects most commonly go down the right main stem bronchus because it is larger and more vertical than the left mainstem bronchus. If we get a PA chest, we would do inspiration and expiration images. The reason for that is when the child takes in a large breath, both lungs will fill up. But if they have a blocked mainstem bronchus, what happens when they expire or blow their breath out is the lung is unable to get the air out and remains inflated. As we all know, children have epiphyseal or growth plates in their skeletal system. When we want to judge the maturation or the age of a child, we need to do a comparison of their growth plates to other children of the same sex and same age to get an idea of, are they growing correctly for their age? If they're under 2, we'll get an AP left upper extremity and a lateral lower left extremity and an AP left foot. If they're over 2, we'll just get a PA projection of the left hand. We take the left side because they are more uniform because they are the non-dominant extremities. Well, let's see what are common fractures in children. Clavicle, humerus, elbow, forearm, wrist, a toddler's tib-fib, and the ankle. These are usually injuries that have to do with motion such as a fall or a twisting type of motion or something that may happen, say, in a sports event. Fractures are pretty common in children, but a good pediatric radiographer should be able to distinguish between common fractures and fractures caused by abuse, child abuse. We'll get into that a little bit later. There are times that we may be asked to do a skeletal survey. A skeletal survey is a radiographic examination of the entire osseous or skeletal system for disease or evidence of child abuse. The study is used to detect changes in the bone structure related to disease or changes reflecting trauma and abuse. Many times with immigrant children or children that come from underdeveloped countries, we x-ray the wrists, knees, and do a chest radiograph to study for vitamin deficiencies, which can result in either scurvy or rickets. Not only immigrant children, but any child that has a vitamin deficiency, usually associated with diet and poor diet. The films of the wrists and knees will usually show the effects of rickets or scurvy on the growing end or epiphyseal end of the long bones. The chest x-ray should be examined for the effects of avitaminosis on the costochondral junctions and the growth zone in the proximal humerus. Take a look at these long bones and at the epiphyseal joints. We see scurvy, and with scurvy there is a lucent band adjacent to the zone of provisional calcification, and it appears in the area in which fractures appear. The remodeling and significant deformity of the long bones in scurvy attest to the potency of the growth and the maintenance of the shape of the bones. Now with rickets, rickets is a systemic disease of infancy and childhood. Calcification of the skeleton is defective due to the deficiency of vitamin D in the diet or the lack of sunlight. Radiographic changes are best demonstrated in the fastest growing parts of the bone, such as the ends of the long bone and the sternal ends of the ribs. Congenital problems, or we were born that way. Many of us have defects that we are born with, and we can fix most of these over a period of time, hopefully, with modern medical techniques. We're going to show just a few of these congenital anomalies. There are many more that you must deal with in pediatric radiography. Congenital spine deformities are disorders of the spine that develop in an individual prior to birth. The vertebrae do not form correctly in early fetal development and in turn cause structural problems within the spine and the spinal cord. These deformities can range from mild to severe and may cause other problems if untreated, such as developmental problems with the heart, kidneys, and urinary tract, and problems with breathing or walking. Here we see spina bifida. It's an opening of the spine. As you know, the spine, the vertebrae come together, and the lamina in the back form the spinous process. Then you have the spinal canal. Well, what happens here is they don't actually form correctly, and we have an opening in the spinal column itself. This can affect both the spinal cord and the vertebral column itself. Most of us are familiar with the term scoliosis. In other words, curvature of the spine, where we have to take x-rays to get an idea of the different angles and what type of treatment can be used. Scoliosis is generally an idiopathic condition. I love that word in medicine, idiopathic. I'm an idiot. I don't know what the pathology comes from. But scoliosis is caused by a congenital abnormality, such as, say, a hemivertebra in this image to the right. Another problem that seems to be fairly common is called hip dysplasia. Hip dysplasia occurs when the joint has not developed properly and the socket, or the acetabulum, is too shallow. This allows the ball, the femoral head, to slip partially or completely out of the joint. Hip dysplasia ranges from a mild abnormality to a complete dislocation of the hip. To demonstrate hip dysplasia, we actually do an AP pelvis and a frog leg pelvis. If you take a look at these images, they were done with gonadal shielding. We do not use gonadal shielding anymore. We use optimal exposure factors, and we don't want to see any rotation or any motion on these exams. Osteogenesis imperfecta is oftenly mistaken for child abuse because basically the bones of the child break very easy. It is a condition that you can take a look at the sclera of the eye, and the sclera of the eye will kind of be blue, and that'll give you a little bit of a hint that the child does have osteogenesis imperfecta. Sometimes it's called brittle bones or glass bones. Here we see achondroplasia, which is often referred to as dwarfism. Clubfoot, or Talipes equinovarus, can be corrected with multiple surgeries over a period of time, but some children are born with this clubfoot, or the foot turned in. It is important to get the images of a child with clubfoot using the appropriate method, such as the kite method. This is a pre-surgical assessment. There is no attempt to straighten the foot, and you take two projections at 90 degrees from each other, or two orthogonal projections, just like you do in trauma. Hydrocephalus. In other words, what we're looking at here is that we have fluid that needs to be drained out of the brain area. So what we need to do here is put a shunt in, and when you x-ray a child that has hydrocephalus, you need to demonstrate the entire shunt going down into the abdomen and even down into the pelvis area. This takes also 2 orthogonal views. Here we see a ventriculoperitoneal shunt. Notice that it goes from the ventricles down into the peritoneum. We have a tube that allows us to drain the fluids. With this presentation, we're barely going to touch on child abuse. There are 4 different types of child abuse: physical, emotional, sexual, and neglect. The radiographer should be aware of all of the imaging signs and the physical signs of these if they work in pediatrics and come across cases of child abuse. The rate of child abuse in the United States from birth to age 3 is usually about 16.4 children per 1,000 children. Why do we say birth to age 3? Child abuse usually happens to the younger child because they cannot talk or tell on the abuser. An estimated 4 million cases of abuse occur yearly in the United States, which results in 2,000 to 5,000 deaths annually. Brain injury is the #1 cause of death in abused children, and 60% or 64% of physically abused children are under the age of 5 years old. All radiologic technologists' careers require the skills, knowledge, and ability to work with individuals and diagnostic imaging equipment. How a radiologic technologist uses the image equipment for children can be different than how a radiologic technologist uses the same equipment for an adult. I want to thank you for your time and actually encourage you to learn more about the skills required for pediatric radiographers.